this was a trial that is a continuation of some work that we started back in 2015 within the NMDP. So we had launched a trial called 15-MMUD, recognizing that there was an unmet need among many patients who just do not have a fully matched donor on the registry or within their family. And that affects between 24% and 79% of patients will have a donor available. And it's based on your ancestry and who's available on the registry. So in the case of patients that do not have that donor available, what is a safe and effective treatment strategy? And in the past, use of a mismatched donor was a risk, and it conveyed some additional risk in the transplant procedure, and was associated with about a 10% decrement in overall survival post-transplant. And that was across the board. And so are there some strategies that we could apply that have been used in other settings? So the use of post-transplant cyclophosphamide as a GVHD prevention strategy. So this is repurposing an old chemotherapy drug after the cells have been infused and are starting to engraft, to kind of eliminate those that are really alloreactive, so that are hyperactive at that time, kind of quiets those cells down. Those are the cells that are really kind of recognizing that HLA disparity. And if you can eliminate that risk, can you use mismatched donors more effectively? So we launched, that's a strategy that's worked quite well in half-matched family members or haploidentical family members. And so we look to apply that in the mismatched unrelated donor space. So we launched a trial back in 2015 called 15-MMUD that was using a post-transplant cyclophosphamide-based GVHD prevention strategy and using mismatched unrelated donors, matched at 7 of 8 down to 4 of 8. So these are patients that did not have a fully matched donor on the registry and did not have a fully matched donor within their family. And what we showed using bone marrow grafts was that overall survival was extremely good, like as good as we see typically with a fully matched donor at 79% at 1 year post-transplant. And so we wanted to carry that forward using peripheral blood stem cell grafts. So 15-MMUD used bone marrow, which is only used in about 15% of transplants today. It's more common to use in pediatrics, but not that common in adults, where we use much more GCSF stimulated apheresis products or peripheral blood stem cells. So we launched the ACCESS trial to now evaluate that same PT size strategy using mismatched donors with peripheral blood stem cells. And we're seeing similar results. We're actually better results. We're seeing 84% 1 year survival using myeloablative conditioning regimens in this latest data that's being presented at the Tandem meeting. ACCESS has multiple strata. So there is a myeloablative stratum for adults, a reduced intensity stratum for adults, and then a pediatric strata. Really focusing on the adult strata, what we noticed was that, well, we did see a much higher ratio of ethnically diverse patients participating in this trial than we typically see on transplant trials. So 51% of the patients that participated on the ACCESS trial are ethnically diverse, where typically in a transplant trial, we see about 10 to 15%. And this has been reported by the Blood and Marrow Transplant Clinical Trials Network just recently in a publication in 2024. So with that, and so within that population, we also saw a higher rate of social vulnerability. So looking at educational attainment, the location that the patients happen to live, their income, and just ability to navigate and support themselves through the transplant process was a bit more difficult within the ethnically diverse population than in the non-Hispanic white population that was enrolled on the trial. And what that really tells us is that there may be additional support that's required for patients to really participate in these trials, whether that's patient assistance grants to help with housing or travel or childcare or other types of factors as part of the transplant procedure. These are complex medical procedures that require inpatient hospitalization for quite some time. At some centers, even being close to the transplant center for up to 100 days post-transplant. transplant. And so being able to support people through that process and then holistically allow them to participate in trials is really important. And that should not be a barrier to participation in these types of trials that are really unlocking some amazing potential for all patients in need of transplant and really eliminating this donor access barrier that we've seen in the past. It takes the entire ecosystem to be able to support these patients through this process. So understanding those social vulnerabilities and needs up front as part of the patient workup, I think is really critical. So involving social workers and others that can help those patients navigate the financial requirements to be able to support themselves through the trial and access grants available through the NMDP is one option, as well as our navigation sources to be able to help patients identify trials and locate those trials and communicate with those centers that are actually providing those trials and understand what the needs may be for them to be able to participate. So we're taking a careful look at this at the NMDP for these trials that we're sponsoring to ensure that we are building in sufficient support mechanisms to ensure that we're eliminating those barriers to participation. And so can that be done through just patient support grants or other types of grants that would allow those patients then to effectively participate in the trials going forward? So it really takes the whole ecosystem working in harmony to make that work and recognizing those needs up front and just being open with those patients about what it will take to participate and what resources are available to help support them through the process is key. An important takeaway is that there is a donor available for every patient in need, essentially. If we are able to use donors down to the 4 of 8 level, as we did through the ACCESS trial, there is literally a donor for essentially every patient that walks through the door. So the donor barrier is gone, which is great news. So that's one thing to take off the table. Then, how do we support those patients through this process? Understanding some of the social vulnerabilities that are there, and nurses and advanced practice professionals can help the patients navigate that process. Some other key takeaways is the results that we're seeing from ACCESS. So 84% survival within the myeloablative conditioning arm at 1 year post-transplant is equivalent to what we see in fully matched transplants using similar strategies and compares favorably to a recent randomized trial that was completed by the Blood and Marrow Transplant Clinical Trials Network that utilized post-transplant cyclophosphamide-based GVHD prophylaxis strategies and matched donors, so matched related donors and matched unrelated donors. There is really no difference between the overall survival between these mismatched unrelated donors and those very well-matched donors on that other trial. So that's really encouraging news. Also, the post-transplant complications that we saw in this trial. So focusing on graft-versus-host disease, which is really what we're trying to prevent here, at the same time trying to cure the patient's disease. The rates of severe acute GVHD, so grades 3 to 4, which would be really kind of severe and debilitating symptoms, was 8% on this trial, which is substantially lower than what we see using traditional GVHD prevention strategies. And chronic GVHD, moderate to severe chronic GVHD, which is really a long-term chronic condition that can be induced by allogeneic transplant, was only 11% at 1 year post-transplant, which, well, actually, it was 10% on the myeloablative conditioning arm, which is quite low. So great news there. That's not zero. So we need to continue to work and iterate and improve upon this process to try and get down to zero. But at this point, the results are much better than what we've seen with traditional approaches in the past.